thinking they're going to be like bad.
They're supposed to have sprayed in West Ashley like last couple weeks, but
It's coming weekend.
end of this week.
Friday, so
Okay.
Hurricane Day.
Good morning.
it's kind of fun.
Beach retreat.
Oh no, that's true.
Don't focus quite yet. Trying to get those online in. Okay, now. Get yourself. Everybody go higher. Okay, that's good. Get yourselves in. Okay. So, Shane, you want to lead us off? What do you see here?
Well, it looks like a subcorneal void or some hemorrhage in there.
Yeah, so this could either be a primary process or a secondary process, right? So there's definitely a huge scale crust on top of it.
Neutrophils. So if it's the granular layer, then I'll be thinking like Fetus foliaceous or Schneid-Wilkinson.
Yeah, so it absolutely could be something like foliaceous or Schneid-Wilkinson and IgA pemphigus.
Friction blister. Are those usually in that area? If it is like
So friction blisters are usually mid-epidermal,
okay.
and it's eosinophilic necrosis of the epidermis. So picture you got, here's your skin, and something's making it go back and forth and back and forth and back and forth. It's going to be right in the middle that it gets necrotic and red, right in the middle of your epidermis. What else do you see here?
There's some leaves
And what are they doing?
lining up on the DEJ.
Why would they line up on the DEJ? Why would they do such a thing? Because that's where the immunoglobulin is, probably, right?
Okay.
That's the usual answer to that. You know Willie Sutton, right? Willie Sutton was a famous bank robber, and when he was being sentenced, the judge asked him, "Why do you rob banks?" And he said, "Because the banks are where the money is." So Sutton's law is you go where the money is. So here the inflammatory cells are just going where the money is, going where the immunoglobulin is usually. So they're a hint to where the immunoglobulin is. What else do you have here in the epidermis?
It looks like sponge, but I think it's actually acantholysis because I don't see the junction between those.
Are the cells rounded up and floating apart, or are they still polygons?
Still polygons.
So if they're polygons, then there's no acantholysis, and you can see these stretched out cell-cell junctions. The spines of the spinous layer is all stretched out. So it's spongiosis. So spongiosis with eos. Do you know anything that could give spongiosis with eos?
Well, like BP is a classic thing.
So BP is one. It sometimes helps to have mnemonics for things. How do you feel when you see spongiosis with eos? You feel very happy. Yeah, so what's the happy differential? You don't want to jump in and help? Herpes gestationis.
Allergic contact, pentavoid, pemphigus, IP, ETN, and I am a doc for a drug or food use and contact.
Very good. So it's a
Happy dog.
happy dog. There you go. So, you know, it helps to have mnemonics in real life and on exams. You get hit by a question, it's just helped to run down a list to make sure you didn't miss anything. So in this case, this is an urticarial BP with secondary crusting. And we know it's urticarial BP because there was linear C3 and an N-serrated pattern. So a sine wave type pattern, which would be characteristic, right? Okay, so let's get ourselves in. Iris, what do you see?
So there appears to be, I guess, separation. It looks like from the basal layer of the epidermis.
Yeah, so it looks like there's nothing left behind on the dermal side. So probably a sub-epidermal split.
And
what's in the blister?
looks like a lot of, maybe some EOs, but then lymphocytes.
EOs, lymphs, newts, so mix. So subepidermal bulla with a mixed infiltrate, but it does contain EOs. And then there's a lot of fibrin in here. So what's your differential?
So it could be a Bolus Lymphedema.
So it could be a pemphigoid, which is what this particular one turned out to be. But what other things can give you a subepidermal bulla with EOs?
Dermatitis herpetiformis.
Yeah, usually not a whole lot of EOs, usually more newts, although you can have some eosinophils. So DH is in there. So if you address this as a neutrophils in the dermal papillae differential, what's your differential for that?
Trying to remember what else. I know there's like the IgA, and I don't know if I remember the other ones.
Okay. Anyone want to help?
Bolus Lupus.
So Bolus Lupus. So again, mnemonics can be helpful sometimes. So that's our plaid differential. Pemphigoid, Bolus Lupus. The A is actually EBA.
EBA, okay.
And then the I is IgA and the D DH. If it has a lot of EOs, it's that differential, with the most likely ones being BP, EBA. 20% of all patients who look like classic BP actually immunoblot EBA, and they turn out to be the ones that A are refractory to treatment and B are sometimes perineoplastic. So, all your problem BPs tend actually to be EBA. And then don't forget bullous arthropod, because that can do it as well. And probably the most common bullous arthropod to do it is scabies, which can give you a positive immunofluorescence. So who gets pemphigoid? Old people in nursing homes. Who get scabies? Old people in nursing homes, right? So, don't forget, because a good long course of Imuran versus one treatment for scabies, the patient may be better off with the correct diagnosis. Okay, Rachel.
Okay, so it looks like I've got, a suprabasilar cleft.
So it's definitely suprabasilar. So everything we saw before was subepidermal. And this is definitely suprabasilar with cells left below and neutrophil crusting up towards the epidermis.
It looks like I've got a lot of eosinophils within my blister cavity.
Yep. So differential.
Help me out. Kind of lost.
Okay. Anyone want to jump in? So
Top three would be BP, arthropod drug with the eosinophils, but it's...
what do you think about it hitting the middle of the epidermis rather than DE junction? So, BP, EBA, less likely. Arthropod certainly could be there. And IgA pemphigus could do this, but it's kind of weird for any immunobullous disease, right? To hit right in the middle. And then one of the clues is you got a courant sitting right there. Occasionally, Grovers can be filled with eosinophils. So, and this person had, 5 biopsies done, 4 were classic Grovers, 1 looks like this. So, remember, Grovers can recruit a lot of eos. This is a courant, that's a courant. So, it can be confusing, especially in your immunobullous differential. But, Grovers is an important thing to remember, that sometimes tons of eos. Okay, Christina.
It looks like a very acute stratum corneum.
So it's a very acute normal basket weave stratum corneum.
With a lot of death in the
And a
epidermis.
lot of death in your epidermis.
So-
It's pretty dead.
So TEN, SJS, I guess, would be my top 2.
Yeah,
You know,
and
where
you've got some individual satellite type necrosis, but not a whole lot of lymphs there. And TEN, Stevens-Johnson, EM usually are death out of proportion to lymphs, so it certainly fits that. Other thing you would think it would be post-cryotherapy could give you necrosis like that. A caustic substance applied, a powerful irritant dermatitis. But a clue to that is often you have coagulative necrosis of the corneum. And here your corneum's really normal. If it were just confluent death with no individual satellite necrosis, you'd worry more about exogenous agents, cryo, something like that. Here we do see some individual cell necrosis with satellite necrosis, suggesting it probably is in the TEN spectrum, which is what the history was.
So, looks like there's a subepidermal
Sub-epidermal bulla.
separation.
And do you see much of any inflammatory cells?
That's pretty posse-immune.
So a pauci-inflammatory subepidermal bulla, is there a differential for such a thing?
So PCT.
So PCT, and so you'd look for sun damage, which I don't see a whole lot of. You'd look for festooning, and you'd look for hyalinization of the little blood vessel walls here. They're really not hyalinized. Don't buy it as porphyria. Porphyria should have red rings around vessels.
EBA is one, and
So EBA can absolutely be pauci-inflammatory, as can inherited EB,
okay.
right? So mechanobullous diseases like EB. Of the immunobullous, the most likely to be pauci-inflammatory is EBA, just as you said. And then BP and the others occasionally pauci-inflammatory,
Okay.
not so commonly. Any other things?
Gosh, the kind of ones that have the confluent necrosis in the epidermis, but I don't appreciate any of that.
Yeah, but here it's not really. So some of the less common ones, a Darier's sign in some with urticaria pigmentosa, where you're just not really picking out the mast cells below, but you have a blister from the mast cell disease. You got a few mast cells here; they look normal. Bolus Lymphedema is a big one. But here you really have no lymphectasia. Bullosis diabeticorum is in that list, and coma blisters. So the story with this one is it was a patient I saw in at St. Luke's in New York, and the resident kept saying, it looks just like TEN, but it's only on one side of her body. And the patient keeps saying it was there when she woke up. So we went into the room and said, when did you fall asleep? Well, I had my GI procedure on Monday. When I woke up on Sunday, I was like this. So she had her GI procedure. She was a 90-year-old woman. She fell into a coma at home, woke up on Sunday, and had this coma-induced blister, which is usually just pressure phenomenon. You know, you're in a coma, you're so deep, you just get a pressure-induced necrosis and blister.
Shouldn't you have, Dr. Elston, eccrine gland necrosis?
So sometimes one of the hints is absolutely that you may see necrosis of the eccrine coil. Your biopsy would have to demonstrate it, and here you got your eccrine coil, and they're about as dead as the epidermis was. Oops, we got a. You said we're still broadcasting when we do this, right?
It's just the TV in here.
Let's try it again here. Can't tell you from the home. There we go. Okay, so let's get that down where these guys were, and you can see your eccrine coil is there, and it's pushing that slide a little bit. There, you can see it. So your eccrine coil is pretty dead, which is absolutely one of the very useful hints to coma-induced blister. Your biopsy has to be deep enough to show that, but if it is, then that's really helpful. Okay. David.
Right. So it is appears to be like a multiloculated intraepidermal spaces or blisters. It's pretty dense, superficial infiltrate. Kind of talk about unknowns over this appearance. Looking for sponges, just could be a Bolus tinea or impetigo, something like that.
Yeah, so absolutely Bolus tinea is in there. Impetigo, probably less so because it's intraepidermal, deeper down, not so much subcorneal. And your major inflammatory cell is what?
So eosinophils.
Eosinophils, which would be, good for a Bolus tinea, good for a Bolus arthropod, less so for an impetigo.
Has PEH as well, a little bit. Something about P. vegetans.
So pemphigus vegetans is also very reasonable in the differential. So that's actually a very good differential. And this one, the history, was a pregnant woman with blisters all around her abdomen and linear C3. So probably herpes gestationis. But your differential was actually very good. Let's see if we can find our tissue in there. There we go.
So it looks like we have what looks to be a lot of, is that almost like hemorrhage?
So there is hemorrhage. So there's necrosis.
Towards the basal layer. I guess it's not as acute appearing. The horn doesn't look acute to me.
Yeah, so the horn doesn't look
chronic.
as acute, more chronic, and that if it's chronic, a lot of the epithelial death can just be old blisters become necrotic. Right? So
Sure.
it doesn't mean that it's necessarily an EM-TEN spectrum. It suggests it's just an old blister that's necrotic for that reason.
And the split is more sub-epi, I would say.
So a subepidermal split,
And
lots of fibrin. It's an old blister, so could this be old EM-TEN? Sure, it could. Could it be anything else that's old and post-inflammatory? Sure could.
so, like, I mean, sub-epi plus inflammatory, like PCT, or
Yeah, and we are probably dorsal hand with that kind of a corneum. Probably dorsal hand or foot. There's a little bit of solar elastosis, so more likely dorsal hand.
right.
So post-inflammatory blisters of the dorsal hand.
So, I mean, EBA can cause it over friction-induced areas, but I think PCT can as well.
So PCT,
So more sun-exposed
EBA.
areas in PCT.
So we'd look for hyalinization around the vessels. Do you see good red rings around those
a little
vessels?
bit there. I would say it's a little bit.
I'd say not so.
Okay, maybe.
Not so much. I mean, they're
Like on the other side of that vessel there, I mean, it's like a little bit of fish.
They usually should be very symmetrical.
Okay.
So if you see anywhere where there's collagen like that sitting right up against the endothelium, you don't have PCT.
Okay. So I would lean more towards EBA.
So EBA is certainly a differential. Other things, think of patients you've seen in clinic who have post-inflammatory bully of the dorsal hands and look kind of PCT-like. What else could be causing it? Anything that you know of that causes pseudo-PCT?
Yeah, like drug-induced, like pseudoporphyria.
Like drug-induced,
Right,
like what kind of drugs?
Naproxen.
Yeah,
NSAIDs.
so naproxen is 90% of the ones you see, right? But there are some others that will do it, including Lasix. So this is a hemodialysis patient with Lasix. They get pseudoporphyria. Sometimes it's just the hemodialysis. More commonly, it's the Lasix that they're on. So that's probably your second most common cause after naproxen. Okay. So, Blake.
Looks like sub-epidermal.
It's
Yeah.
definitely a subepidermal split.
Looks pretty.
right?
The epidermis looks thin.
Epidermis looks pretty thin. It's subepidermal.
A few EOs.
Few EOs, so fairly post-inflammatory, but definitely a few EOs. Now comment on the skin itself. Do you see much of a dermis?
Not really.
Not really. It's certainly not bundled much, right?
Mm-hmm.
But you have lots of fibroblasts. Hair follicles are tiny. The fat is tiny. This is infant skin, right? This is baby skin. In fact, with the dermis that poorly bundled, it's probably really, really, really young, like fetal skin. And so you have fetal skin, and the fetus is blistered. What things might you think of a post-inflammatory blister in a fetus?
Bullous dermatosis. Childhood.
So, chronic bullous disease of childhood is usually, 5-year-old, 6-year-old, 8-year-old, 10-year-old. I've never seen it as a, neonatal or intrauterine process.
One of the inherited.
So one of the inherited
disease.
EBs, absolutely. So, that's possible. Could this be a fetus who died because of a lethalis EB junctional? Absolutely. But you did mention a few EOs in there, right? So any immunobolus disease mom could have had that could have passive transfer of antibody to baby blisters, and it's associated with prematurity and low birth weight and
BP.
so and what do you call BP pregnancy?
Impetigo herpetiformis.
That's
herpes.
That's pustular
Yes.
psoriasis of pregnancy. So
Herpes
the names are horrible. Impetigo herpetiformis has nothing to do with impetigo, except that it was pustular, right? It's pustular psoriasis of pregnancy, and herpes gestationis has nothing to do with herpes, except that sometimes they're clustered, which means they're herpetiform, the blisters. But so this is, your differential is right, spot on, that this would either be an inherited mechanobolus EB that was, lethal in the child, or in this case, it was child born very premature, low birth weight, of mother with HG, pemphigoid of pregnancy, and has blistering disease as a result. So a lot of these you can get as far as a differential because you need IF. But you could still, the way they could be questions is either with IF, which would be more real life, or with a differential where of your differential only one is possible. Right? Because the others just don't fit with what you're seeing. Okay, Brian.
Okay, so large sample on this one.
Big sample. Yep.
Seems to be centrally acanthotic. I thought it was just the way it was cut, truthfully.
Yeah, but it definitely is acanthotic, even though there's probably a little bit of an oblique cut.
Trying to appreciate. I mean, you got a lot of ink there, but it looks like you're missing a fair share of the corneum above a granular layer.
Okay. And is your granular layer normal?
No, it's a little bit, I would say, darker, thicker.
Yeah, darker, thicker. So thoughts?
So maybe would that be dyskeratosis?
There is dyskeratosis there.
It is focal, too. You got the underlying inflammatory.
So do you know anything that causes a focal acantholytic dyskeratosis?
So this would kind of fall into the Grover's versus warty dyskeratoma.
Yeah, and is this one big thing, or is this multiple little foci across the field?
It looks like multiple foci.
Yeah, so why is there so much ink on this? Because this is probably an excision specimen from a melanoma or a squamous or basal cell that just has lots of Grover's in the background. Right? So Grover's disease, transient acantholytic dyskeratosis. This field there is diagnostic of Grover's. See those few little corons? There, here, down there, some grains. That's diagnostic. And the finger-like projections, that acanthosis that you picked up on, is typical. So the fellows early in the year often want to call these an AK or a lentigo because of that finger-like proliferation of the epidermis. The key is if you've got the corons and grains there, it just goes with the acantholytic dyskeratosis.
What's the difference between that and Dariers?
So would look the same.
It would look the same. Okay.
Yeah. The difference is Dariers only knows how to do acantholytic dyskeratosis like this, whereas Grover's can be a mix of one little area has a pemphigus pattern, another has a foliaceous pattern, another looks like Dariers. So if you see the mix, you know it's Grover's.
Okay.
Grover's tends to be multiple smaller sites. That one thing we saw where you just had a little bit of proliferation and just two little corons there, that's more Groverish. Okay. Dariers tends to be more exaggerated than that. And if you've got it full of EOs focally, that's towards Grover's, because the other Dariers doesn't do that. So they can be indistinguishable, or Grover's can be diagnostic because it's multifocal and smaller, more diminutive, just a little bit of epithelial proliferation, finger-like proliferation, just a few corons, a mix of acantholytic patterns, or EOs present. Any of those, pretty much it's tipped its hand and told you it's just Grover's.
run a lot of, it looks like neutrophils and EOs along the DEG.
So a few EOs, more newts, DEJ, and does it have any tendency to accumulate anywhere?
Yeah, kind of along the dermal papillae.
In the dermal papillae, and characteristically with fibrin present.
Okay.
Right, so newts, fibrin, a few EOs concentrating in the papillae, although they also run down the hair follicle here. So what's your differential?
It would be the plaid differential.
So what's in your plaid differential?
So you have dermatitis herpetiformis, the IgA,
Yep.
got EBA, lupus, and then pemphigoid.
Yep. Very good. And then, you just between clinical and IF, then you know what the patient has. So, they basically get you to a short list of what the patient could have. Okay. Caleb.
Here I have a pretty infiltrate of eosinophils.
So mainly EOs,
Yeah.
and what are they doing?
They're lining up along the.
Lining up along the DE junction. Why would they line up along the DE junction?
That's where the money's at.
Because it's what it is, just like Willie Sutton, right? Why would you rob something that's not a bank, right? What would the point be? That's not what the judge was asking. That was his reply that made him famous just before he was hanged. Was, why would you rob anything else? The money's in the banks. So, it lines up because that's where the immunoglobulin is. So, what would your differential be?
Is this the happy differential?
No, that's
No.
spongiosis with EOs.
Oh.
This is EOs at the DE junction.
I have like EBA and BP.
That's pretty much it.
Okay.
BP and EBA. It's one of the two. And if the patient is more refractory, more likely EBA than BP. And any things that on IF could tell you the difference between the two.
The inserrated and euserated.
So
patterns.
N-serrated versus U-serrated pattern, and what do they look like? Draw it out on a piece of paper. What is N or
The
U?
inserrated one is like a sine wave.
Looks like a sine wave. Very good.
Euserated kind of comes like this.
Has upward spikes.
Yes. And
Like a series of lowercase n's, or a series of lowercase u's, shockingly enough. So a sine wave is an n-serrated pattern, and then the upward spikes of the u's is very characteristic, and Sally Self is reading them out that way for us because it's very helpful. If you're having trouble interpreting it, then you can do salt split skin. And you can do that one of two ways. You can split this specimen with salt, or you can run an indirect on salt split normal skin. So you take normal skin or lesional skin, and you incubate it overnight in 1 molar sodium chloride, and then you just kind of rub it a little bit, and the epidermis comes right off. And that, there's no real magic to it, and then you see which side it's on. If it's on both sides or the roof, it's probably BP, whereas EBA tends to be solidly down at the base. What if you've got a disconnect where you've got an N-serrated pattern? It really is an N-serrated pattern, but on salt split skin it seems to be the base.
P200.
That's anti-P200 pemphigoid. So anti-P, and that's kind of classic for anti-P200 pemphigoid. So it's a different antigen. It's not the BP180. So anti-P200 pemphigoid tends to hit just a little bit deeper. So you still have an N-serrated pattern, but it looks like it's on the floor with salt split skin. Well done. Okay, let's try to do things we have not done before.
So to me, you got an acute striatum corneum. The other area really showed that you had more sort of a lichenoid or interface on the other end of the specimen. In that area, it looks like more.
So you could approach this as a bullous disease differential or as an interface dermatitis differential with an acute horn.
Yeah, and you have dead reds really throughout the entire epidermis. I feel like when I see that combination, I think of EM, and when you think of EM, you have to consider SGS-TEN also.
Absolutely. So EM-TEN absolutely would be top of the list. One other thing, though, is why is there this ropey collagen above the postcapillary venial?
So you can think about like bullous fixed drug too.
That would be the other thing, would be fixed drug, which is what this one turned out to be. But so it's absolutely an EM-TEN, like pictures, sub-epidermal blister, forming by individual cell necrosis, satellite necrosis, an acute corneum, so very EM-ish. Hints that it could actually be fixed drug would be a more polymorphous infiltrate that contains eos or newts, deep pigment around the postcapillary venial, or ropey collagen above the postcapillary venial would all be hints.
So I see what looks to be a pretty good suprabasilar split with some villi formation.
So suprabasilar split, villi formation, what used to be a prophetic tombstone row back when pemphigus was 100% fatality, which was not that long before I started residency. It had 100% mortality. And then the data when I was in residency is it still had 100% or close to. It was just delayed, and it was side effects of medication that caught up with you. And now with rituximab and other things, I think we're running like 18%. So, you know, things have definitely changed for these people.
So sort of the favorite pemphigus vulgaris. There is some Corons looking things in there.
Yeah,
You'd
that's a
wanna
little...
consider Haley and Morty D and other things.
And this particular one, even though kind of hard to tell because it looks like it's fairly keratinized, but this was mucosal and was a pemphigus vulgaris. What glues do you have in skin to hold your cells together?
Desmoglein.
Which ones?
1 and 3.
Which ones do you have in the mucosa?
3 mostly.
Yeah,
Only
pretty
3.
much only 3. So when you have pemphigus foliaceus, what does it target?
1.
And so where are your blisters?
Upper epidermis.
And
Subcorneal.
ever in mucosa?
No.
Is there any desmoglein 1 in mucosa? No. So you never get mucosal involvement because the antigen's not there. In vulgaris, do you get mucosa as well as skin?
Yes.
And what presents first usually in vulgaris?
Mucosa.
Why?
Because it usually starts with 3 and because of the rapid turnover, I think.
Yeah, I think both, but the easiest way to think of it is your skin's being held together by 2 glues, desmoglein 1 and 3. Your mucosa only has 1 glue, desmoglein 3. What is the antibody targeting? Desmoglein 3, right? The other thing that you'll see is patients whose skin looks really good and they still have bad mucosal disease. So how can their skin look so good and their mucosa looks so bad? Because their skin has 2 glues and their mucosa only has 1 glue. So you're still targeting that 1 glue. So you will see patients who, their skin looks great and people are letting up on therapy and they've got stridor and they have, their epiglottis is just blistering. So, pay attention to the mucosa because that's the first and the most refractory. Let's see what else we got here.
So it looks like the splits in the granular layer, but you have some microkeratosis, some parakeratosis. Maybe
And is your epidermis normal or is it acanthotic?
they can.
So you got an acanthotic epidermis, you've got some
Some
hyperkeratosis,
You have some acantholysis in there, or maybe some dyskeratosis.
some acantholysis and some dyskeratosis. So what do you think?
Well, something like the parakeratosis and hyperkeratosis, Darius.
Yeah, Darius or Grover's, could be either one. Let's see what we do here.
So the split here seems to be more so, I guess, at the granular layer.
Yeah, so subcorneal split, granular layer split.
Looks like maybe I saw some loops and there's, so that would be a crust kind of on the other end.
Yep.
So, and would that be a microabscess there?
So there is a little neutrophilic microabscess, but it's not in the papillary dermis. It's up in the subcorneal.
So when I think of subcorneal blisters, I think of pemphigus foliaceus.
So foliaceus,
Snedden-Wilkinson.
Snedden-Wilkinson, a lot of which. So Snedden-Wilkinson probably isn't a disease of its own. Half of it is IgA pemphigus, and the other half is psoriasis. So Snedden-Wilkinson presentation, which is, then your job is, am I going to treat this like psoriasis, or am I going to treat this like an immunobolus IgA disease, and that depends on your immunofluorescence. So those would probably be the highest in your differential. Remember scabies in your differential. There are a few EOs down below. Bullous-tinea, impetigo. All of those things could give you a blister like this. That one actually was a patient with vegetans, but it's more a foliaceous type pattern that you're seeing there with secondary crusting. Okay, so your epidermis fell off, and not only your epidermis fell off, but your entire hair follicle came out with it, right? So it's not just your epidermis peeling off, but the whole hair follicle just popped right out of the skin. And what do you see below where that epidermis peeled off, taking the follicle with it? Little round cells floating away.
Yeah, I guess so.
So that's acantholysis. So what kind of acantholysis will make your whole epidermis peel off and the whole follicle go with it?
Be like TVN or Stevens-Johnson.
That's usually necrosis of the epidermis, individual necrosis, and I've never seen the whole follicle come out like that. What disease loves to extend down the follicles? It's pemphigus vulgaris. Yeah. So that's what you'd expect. And then you look at the other piece and you see that tombstoning of your basilar keratinocytes on the papillae. So pemphigus goes deep, deep down along the follicle, and you can have, when you blister, not only the surface epidermis, but the whole follicle just comes out with it because of that split. Of the two diseases, so Christina, pemphigoid, what do you have to have in order to blister? So your choices are A, immunoglobulin, B, complement, C, inflammatory cells, D, all of the above.
So for pemphigoid, it has all of the, no, just complement?
No, all of the above. All of the above. Pemphigoid, you will not blister unless you have all of the above. You must have immunoglobulin, complement, inflammatory cells. If you don't have all of the above, you cannot form a blister in goid. How about in Gus?
You just have to have immunoglobulin.
Immunoglobulin alone. That's all you need. So when you are targeting those diseases, how many options do you have for treating goid versus Gus?
I have a lot more options for goid.
A lot more options. So why do things like tetracyclines work for goid that are anti-neutrophil? Because you don't blister unless you have immunoglobulin, complement, and inflammatory cells. You can target any one of the three in goid and make people get better. In Gus, all you need is antibody to form blisters. So what do you have to target?
You gotta kill those B cells.
You got to kill the B cells. Exactly. So, for a lot of our patients, if they have serious disease, it's a pretty short road to rituximab. Or things like azathioprine, mycophenolate. You've got to do something that is going to shut down immunoglobulin production. Because that alone is what's required for blistering. Again, we got a pretty big piece of tissue, and as we look across the tissue, we've got one little thing here, and what's the pattern there?
Acantholysis, dyskeratosis.
And what level is the split?
Intraepidermal.
Intraepidermal and probably suprabasilar, almost like vulgaris, and then over here you've got more corons. So they're little. They do have that finger-like projection of the epidermis. This one has a few eos in it. They're small, and the pattern changes. How likely is it that this is Darius?
I would say it's unlikely that this is Darius.
Yeah, that's more a Grover's pattern, right? The pattern changes, there are eos, there are little foci, and it's a great big piece of tissue that looks like it was a tip of an excision, right? So probably an incidental finding there.
So I'm seeing some. That looks sub-epidermal there.
Yeah, they're kind of in the
And
dermal
there's some
papillae.
corons in there. Or dyskeratosis.
Yeah, some dead reds.
Okay.
I mean, that one does look a little corondish, I have to say. But some dead reds, newts in the dermal papillae. So what's your newts in the dermal papillae differential?
That is the plaid differential.
Yep. So plaid differential, so pemphigoid, Bolus lupus, EBA, linear IgA, DH. There's a twist here, though, because underneath there's a leukocytoclastic vasculitis. Vasculitis, those newts can travel up and mimic DH, mimic immunobolus. So if you see a shave, a superficial shave of a vasculitis biopsy, it can mimic a plaid differential of immunobolus just because those cells are going up. So look at the history. This is not that uncommon a phenomenon. So you get a superficial biopsy, you have newts in the papillae, but the clinician's history is rule out vasculitis. Well, that may just be the vasculitis. And then the third thing here, this is a 3-fer, is they're nevus cells, and they're in erector pili. So this is vasculitis in a congenital nevus, giving you plaid-like sub-epidermal bully.
Touch biopsy. Looks like the stratum corneum is kind of starting to fall off.
Yeah, so your corneum's peeling,
Epidermis.
Do you see any acantholysis, though?
Not really.
Not really. In fact, I still see some corneum below. And the main purpose of this slide is artifactual splits in the corneum versus real.
Mhm.
If that were foliaceous, you would expect float-away cells at the base, and just as in Star Trek, Klingons at the top. Right? The Klingons are clinging on to the underside of the corneum. So you got Klingons and floataways. And neither one is present here. Suggests that that's probably just an artifactual split in the corneum. So what else is going on in this slide?
Ooh, it looks pretty sclerotic.
Looks pretty sclerotic. Where's your space between your collagen bundles?
Gone.
There it's gone. You've got big hyalinized collagen bundles, no space between them. What does it look like?
Like morphia?
Looks like morphia, right?
Square
I don't
box.
see any inflammatory cells, but morphia, scleroderma, sclerodermoid GBH, and this was sclerodermoid GBH, this particular one. But the apparent split in the corneum you can tell is artifactual because there are no floataways, no Klingons.
Alright, so we're on hair-bearing skin. Looks like we have a sub-epidermal split.
So you got a sub-epidermal split,
Palsy, inflammatory.
palsy inflammatory, and what else do you have?
Looks like. Let's see what's in there.
My fibroblasts are all going east-west. My blood
Right,
vessels
it's
are
a
going
scar.
north-south.
Like a scar.
So you got a lot of scars.
Right.
So why do you have all that scar in a palsy inflammatory subepidermal blister?
Probably PCT. Don't you see scarring?
So PCT or
Some prior process, like a procedure.
what other scarring, mechanobolus,
Oh, EBA.
not EBA, but EB. Right? EBA is immunobolus and inherited EB is mechanobolus.
Oh, okay.
Okay. So this is a scarring, palsy inflammatory subepidermal process. So my guess would be mechanobolus inherited.
Looks like a scale crust.
So you got a scale crust, and then what else do you have?
There's a lot of acantholysis.
There's acantholysis, and is it just acantholysis, or is there acanthosis as well?
That as well.
So there's acantholysis and acanthosis
It
with
looks
a
pretty
scale
full thickness.
crust, and it's pretty full thickness, and there are rings around the
red rings.
nuclei, and they're only red.
Haley.
There are no blue ones, no clear ones. So that's Haley. So Darriers can make red rings, blue rings, clear rings, usually a combination. So Darriers, you usually see red rings, blue rings, clear rings. Haley only knows how to make red rings around the nucleus. Right? So acantholysis, acanthosis, full thickness dilapidated brick wall, acantholysis, and red rings only around the nuclei. No blue, no clear. Haley. Who described it first, Haley or Haley?
Yes.
I think they were brothers or father son. It was one report.
It's another similar looking slide here. Lots of, it looks like acantholysis, or at least, yeah, it looks acantholytic.
So acantholytic.
And then,
Are there any dyskeratotic cells?
Yes.
What color is the ring around the nucleus?
These ones are also red.
So
Pink.
I'd say there is red peripheral, but what color is immediately around the nucleus?
Blue, so this
Blue. So is there any chance on the face of the earth that this is Haley?
no.
No. Haley only knows how to make red rings. This one has a blue ring staring you in the face, right? So no way, even though this is a full thickness, dilapidated brick wall, acantholysis with acanthosis, no way that's Haley because I see a blue ring. Haley cannot do that. So what could it be?
Could be. I imagine Grover's more so than actually Derrier's.
So Grover's Derrier's. This is isolated bumps only in the genitalia. So there is a condition called vulvocrural acantholytic dyskeratosis that looks kind of like Derrier's. It's not Derrier's. It's not inherited. It's acquired. And it's just vulvocrural area. And what you see is acantholytic dyskeratosis. And it's benign. And it often presents in kids. And the parents get charged with abuse because there's something going on in the genital area. So that and localized cicatricial pemphigoid of the vulvocrural area, both common conditions. They are, of the ones that Derm sees, they're the most common things where the parents are charged with abuse and there's no child abuse. It's a dermatologic condition. The other one is occasionally you'll see EB, where it looks like a scald injury on a foot or on both feet, and by the time it is worked out that there is a mechanobolus disease, sometimes the parents have lost custody. I mean, it can be pretty bad. There was one horrible case that was written up. The child had vulvar cicatricial pemphigoid. Dad was convicted of child abuse because of the impassioned testimony of a pediatrician who had been a victim of abuse once herself, and this could only be child abuse. Dad went to prison. Child continued to blister and have progressive scarring. The diagnosis was made. Dad's sentence was commuted, but because of the law in that state, he has to register as a sex offender for the rest of his life. He cannot be at school. He cannot be, all of those things in place because of laws that were well-meaning. And, this guy was completely innocent. So, you see tragic cases like that. Tragic for the child who lost her father, tragic for the father, tragic for the child who went on to scarring with not adequate treatment of immunobolus disease. So, lots of different aspects. And we are out of time. So, then we're done. Yes, on that happy note.